Good morning, everyone. My name is Eric Clark. I'm the chair of the CPD committee at CAPE. I'd like to welcome you all here. We have yet another really interesting and I think useful breakfast symposium this morning on thrombotic microangiopathy. We have three wonderful speakers, Drs. Lang, Germini, and Sang, up here who are going to walk us through a number of challenging cases I think I know I've struggled with in the past. So I'll invite Eddie up to sort of walk us through and introduce everyone.
Thank you, Eric, and good morning, everybody. Great to see you all. Hope you had a wonderful evening. Just wanted to start with a shout out to our colleagues in Halifax who are going through a very tough time with the fires. Our prayers and thoughts are with you. So it's my pleasure to be the moderator for this really cool symposium on thrombotic microangiopathy. I'm Eddie Lang. I'm from the University of Calgary. And it's on behalf of CAPE that I'm really excited to be here and happy to present be the moderator for this symposium. Share my disclosures, relevant disclosures. We're all receiving an honorarium from CAPE for this presentation. And it's important, I think, that we note that this program was independently conceived by the Scientific Planning Committee for the conference. It received an educational grant from Alexian, and all efforts were made to eliminate any, mitigate any potential biases. And I'll also now run through the faculty disclosures for our co-presenters who will be presenting shortly. So this is for Dr. Tseng. I'll let you have a look at that. And then for Dr. Germini. So as we have been doing and using very effectively, you'll find tiles on your table to help. Oh, no, those aren't good. Those aren't the right tiles. So this is the Slido for this presentation. It's 407-3354, and we'll bring that up later. Do not use the tiles that are on the table. And then just as a reminder, so you can scan that or put that into Slido for questions and for polling. And you're going to see it in two features when you go into your Slido app, either the poll tab or the Q&A tab, where you can put in your comments and questions. And of course, we have floor microphones, and you are more than free to use those, of course, to bring up your questions. So look, we've got three really cool cases that are going to be presented. They're very emerge focused. They're going to present some of the interaction between what could occur between emergency and a hematologist. Just to review, what we're hoping that by the end of this session, you're going to be able to describe an approach to thrombotic microangiopathy and to thrombocytopenia, provide a differential diagnosis, and have an approach to providing a collaborative, multidisciplinary, and coordinated care for a suspected TMA. And as Eric suggested, this is a very high-risk condition with a lot of potential for rapid deterioration, and we're hoping to raise awareness and make you a hero in diagnosis if we can pick these up in a timely manner. So just let me first then go on to introduce our two speakers before I hand this off. Dr. Federico Germini is an emergency medicine specialist, completed a fellowship in adult thrombosis medicine, and has a master's in health research methodology. He's currently an assistant professor at McMaster in Hamilton and has a research educator role, a PhD candidate in health research methodology. His research interests include venous thromboembolism, hemophilia, and patient-reported outcomes. Also has a very cool Italian accent, as you'll hear shortly. Dr. Eric Tseng is a non-malignant hematologist who works at St. Mike's in Toronto. His clinical practice is focused on thrombosis medicine. Academic interests are in residency education, CME. His hospital is a referral center for apheresis medicine, including thrombotic microangiopathy. So over to you, Eric. Dr. Tseng.
I'm an outsider here, but I work with Emerge Docs, obviously, at St. Mike's, and I was on call over the weekend, actually. And last night, I did hear about a case of query TTP from the Emerge, so timing works out really nicely. I recognize that thrombotic microangiopathy is a term that is discussed a lot. People say MAHA, TMA, TTP, atypical HUS. It's a bunch of like consonants and letters, and it's really confusing. So I think the purpose of the reason why this is an important topic is because I think there are things that we can do. There's just a couple things that you need to be able to recognize and say, could this be a life-threatening condition or not? Do I need to ask for help and escalate immediately? Or is this something where the pretest probability is a bit lower? So the purpose of today's session is really to try to identify those red flags. And as a hematologist on the other side, what are the things that I listen for and might be asking about when trying to decide, is this something we need to act on right away, or do we have some time? So I just wanted to go through the term thrombotic microangiopathy, or TMA. Really, this is a grab bag term, and there's two components to it. There's thrombocytopenia and what we call microangiopathic hemolytic anemia. What's happening in these conditions is there are microthrombi that are depositing in the small blood vessels. So you've got small blood vessels all over your body, brain, heart, kidney, which leads to some of the manifestations that we'll talk about a bit later with TTP, for example. But when thrombosis happens in these small blood vessels, microthrombi, platelets become consumed. When platelets become consumed as part of the coagulation process, thrombocytopenia happens. When you have thrombocytopenia and clotting happening in these small blood vessels, you can imagine the caliber of your blood vessel narrows, right? So the caliber of your blood vessel narrows as these clots line the microthrombi. Red cells try to squeeze through, and they shear. So that leads to fragmentation, or what we call schistocytes on your smear. And that's really what this comes down to. It's a mechanical process and a thrombotic process at the same time. That's why you see thrombocytopenia and you see mechanical injury, which is schistocytosis or fragmentation. And so when you think about the end organ manifestations, the target organs are where you have small blood vessels. So brain, kidney, heart, and then you see fragmentation and thrombocytopenia on your smear. So how do you recognize a TMA? We'll go through some cases, but really thrombocytopenia and hemolytic anemia. So bottom line, thrombocytopenia, hemolytic anemia. How can you support the diagnosis of hemolytic anemia? The test that you would look for, which you might not order at the outset, would be a lactate dehydrogenase, or LDH, indirect bilirubin, and then as a compensatory response, you could see a high reticulocyte count. Now, sometimes an early clue to a high reticulocyte count is a high MCV, because reticulocytes are larger, and so you might actually see, surprisingly, a slight macrocytosis as well on your peripheral, on your CBC. There are some labs that will go down as well. Again, these are not labs that you would typically order right at the beginning, but a haptoglobin will be typically undetectable in someone who's actively hemolyzing. You've got a low hemoglobin, and then thrombocytopenia as well. So I'll just leave this slide up here, and you can just think about, if you're thinking about like hemolytic anemia, then you might want to add these investigations on just to get the ball rolling. Otherwise, it could lead to a delay in diagnosis. At the hospital where I work at, we can typically just call the lab and add these tests on, but it'll obviously vary in terms of where you work. So how does TMA actually happen? So I think it's really confusing because there are many different reasons why TMA can happen. I think it's helpful to think about it in terms of pathophysiology, and I'm not going to focus too much on this, but I think if you have a sense of this, then it really helps to frame like what's happening with your patient. So the number one thing you cannot miss, or you need to flag, that will get medicine and internal medicine and hematology, get our ears really like perking up, is, could this be TTP? Bottom line, TTP, right? Fatal condition if not treated, and this is something that just cannot be really, is one of these things that if you can get treatment started quickly, then you can make a real difference for your patient. So what TTP is a deficiency in an enzyme called ADAMTS13. I will talk about this in a subsequent slide, but this is what it is. It's a deficiency in ADAMTS13. Atypical HUS is a similar condition wherein complement is activated. And then the phenotype of these patients is slightly different. Shiga toxin is typically seen in children. This would be what we call HUS as opposed to atypical HUS. And then there are a whole bunch of other illnesses that can lead to thrombotic microangiopathy, things like HELLP syndrome, malignant hypertension, even cancer can lead to findings that are consistent with TMA. But there are things that can distinguish these patients from patients with TTP, atypical HUS, and Shiga toxin. So just keep this in mind as we go through. I think if you could take one thing away from today, thrombocytopenia and hemolytic anemia is usually bad news. Thrombocytopenia, hemolytic anemia, usually bad news. So I actually want you to turn to your colleagues. I know you're eating breakfast, just waking up. Just spend like a couple of minutes getting to know each other, and also think of a few reasons for why you could see this pattern of things happening. And some of it's on the previous slide. I'm not going to go back, so see if you remember what was on the previous slide. But also think of these other things that come up. I'll give you guys a couple of minutes. That was like 60 seconds. I learned that when the room starts getting louder, people are probably talking about other things. Any ideas? Just shout it out. Any ideas? DIC. Yes. Any other ideas? Well, luckily I have an answer slide. So, so these are like 5 things. We'll talk about these, but TTP, atypical HUS, Evans syndrome, which is ITP plus autoimmune hemolytic anemia, DIC, thank you, and then HELLP syndrome. So again, these are all things that are worrisome, need immediate treatment, potentially life-threatening. So short differential, right? Thrombocytopenia, hemolytic anemia. However, so as a hematologist, I often get consults and people say, I see fragments on the smear, could this be TTP? And so I guess one of my key points to you is most of the time it's not TTP. There are many reasons why you can see fragments on your smear. So the things on the left are things that we really need to think about and should try not to miss. There are things on the right where you can still see a bit of fragmentation, but causes that are frequently overlooked. The case I heard about in the Emerge last night, by the way, was probably someone who had maybe metastatic cancer, and they had a few fragments, but so most of the time it's not going to be TTP. So the things that you can think about, metastatic malignancy, sepsis, there are certain medications that can cause fragmentation, patients who have had a bone marrow transplant, and scleroderma renal crisis, and then also your patients who have mechanical valves. So the shear and endocarditis, these are things where there's a bit of a mechanical component, and these patients can often have a bit of fragmentation as well. Okay, so I'll turn it over to Federico now.
So thank you, Eric, for the introduction. You're now well warmed up, hopefully also well fed, and we can start with the first case. You are working in a rural emergency department assessing a 48-year-old female, previously healthy, that presents with a 10-minute history of a facial droop, dysarthria, and arm weakness. The symptoms completely resolved before you see her, and the non-contrast CT head is normal. You run the first lab work, and you see that the hemoglobin is 90, platelets are down to 4, white blood cell 8. So this is not a straightforward stroke case. Already clinically, there is dysarthria, not aphasia. The hemisyndrome, an incomplete hemisyndrome with it, negative CT. You start wondering what you should do. You're not happy of giving antiplatelet agents to a patient with such low platelets and anemia. So maybe it's time to call a hematologist or a neurologist. We already know Eric, so why don't we call him? Eric, what do you suggest to do next?
Hello? So has anyone seen a case like this before? So this is really scary, right? A young patient with no cardiovascular risk factors with a very abnormal CBC, assuming that the platelet count is real, that it's not platelet clumping, what are some of the investigations that you'd want to order? So it's all the investigations that were on the previous slide, right? So, confirm if the patient might be hemolyzing. Think about TTP in this case. So LDH, indirect bilirubin, reticulocyte count, peripheral smear to look for fragments. Creatinine is helpful for a few different reasons, namely because it can help you differentiate between a case of atypical HUS and TTP. Not that that's going to be your primary concern diagnostically immediately, but you're going to want to have that as well. And then I think DIC was mentioned as a possibility earlier on. You need to have coagulation profile as well. A patient who has TTP should not have abnormal coags generally. So normal INR, normal PTT, normal fibrinogen would be supportive of a diagnosis of TTP, which is, I think, really the primary concern here when you see severe thrombocytopenia in a young patient who's had clearly, very likely has had an ischemic event. So let's look at these are the investigations.
I thought we were asking him, and instead he asked us, but in the end we got the labs. LDH is elevated, creatinine not much, APTT, so the coagulation times, INR are normal, fibrinogen is not consumed, if anything it's on the high side, and I leave to you the blood smear. Oh, I went, oops. Go ahead.
So I'll just pause on these, thank you. I'll just pause on the investigations here. This is a pretty classic set of labs for TTP. Very high LDH, severe thrombocytopenia, normal coagulation profile, including normal fibrinogen. And then you're looking for fragments. So if your lab reports fragments in your EMR, great. If not, you can call the lab, or internal medicine should hopefully be calling the lab to confirm what's going on. So if you were to call us overnight, we would look at the peripheral smear, and you will rarely be doing this, but this is what a normal peripheral smear looks like. You've got lots of red blood cells. They look nice and round. They look like little donuts. You might see little tiny purple dots. Those are platelets. So you can see them all over the slide, they're like tiny, tiny little dots. This is what TTP looks like. So when we look at this overnight, TTP, you can see there's none of those purple dots are present, those tiny dots. That's severe thrombocytopenia. And you can see there's like red cells there that look like they've been shredded. That's what fragmentation looks like. And so if you see enough of those fragments in severe thrombocytopenia, you're thinking that this could be TTP. So we've got a polling question here. Which of the following is true about this patient? Okay, session is over. I'm just kidding. Okay, let's talk about this case. Okay, this patient has TTP. We talked about this, but TTP is ADAMTS13 deficiency. What's happening is, so this is the surface of your blood vessel, your endothelium. Von Willebrand factor is produced within the endothelial cell, and it basically extends into the blood vessel. It's like a big Velcro. And so you need ADAMTS13 to cleave it. Otherwise, platelets will stick to it. So platelets are zooming by. This VWF is floating around. It's like a Velcro. And so if you have anything that's causing a functional deficit in ADAMTS13 activity, what will happen is this Velcro just stays there. So the body makes antibodies against this really important enzyme. And as a result, you've got this huge Velcro, platelets stick, severe thrombocytopenia, clotting happens, and then fragmentation, et cetera. So why are we talking about this so much? This is a fatal condition with up to 90% mortality if it goes untreated. And really, the reason why St. Mike's is an apheresis referral center, this is where I work, is we get criticals very frequently for patients with suspected TTP. So urgent recognition, transfer, and specialized therapy. I think, depending on your work setting, I think you can probably frame how this goes. Like, often the diagnosis, the recognition is delayed. And so when you're giving a consult, it would be very reasonable to suggest, I'm not sure if this patient has TTP, but I'm concerned about it. I've done this and this and this, and I'm really worried about this. I suspect probably you'd be referring this to an internal medicine service, but if you're really worried, you could even think about criticaling the patient, actually. It really depends on where you're working in the setting there. And the reason is these patients need plasma exchange. So when do I worry about possible TTP? So these are some of the key things that you can look at, and these are all present in a case. Severe thrombocytopenia, so to me that's a platelet count of less than 30. Relatively preserved renal function, normal coagulation parameters, fragmentation, and then if you have evidence of end-organ dysfunction, so they might have a high troponin, they might have a neurological deficit, and these are some of the things that differentiate it from some of the other things. So atypical HUS, which we'll talk about later, usually have abnormal renal function. DIC will usually have abnormal coagulation parameters. And guess what? There is something in MD Calc that you can use too. So the plasmic score is a pretest probability score that I don't use that often, but I think it's really useful to have this in your back pocket because you can just look it up in MD Calc or on Google, and the same things that are on the slide here are in the score. So if you can actually, even if you don't remember this, you can go to this plasmic score and then actually look up some of these parameters. The tricky part is going to be remembering the name of the score, but it's there in MD Calc, and I would suggest that you refer to it if you're not sure. We've talked about this, but this is the workup that you would send off. The key difference, the key other test would be what we call an ADAM-TS13 activity, and so this is a coagulation test. It's a blue top tube. It gets drawn before any treatment is started. And then it can be banked and then sent to wherever the patient's being sent to for advanced therapy, and then they can run the test afterwards. So how to manage this? Ask for help. Bottom line, ask for help. These patients need therapeutic plasma exchange to remove the inhibitor that's causing the ADAM-TS13 deficiency and to give them ADAM-TS13 back. So that's how we reverse this process acutely. These patients get corticosteroids, and then there's other things that we would add, DVT prophylaxis, aspirin, et cetera. But the key is urgent consideration for therapeutic plasma exchange to really clean the blood of the inhibitor and give them back ADAM-TS13. The other thing is, we're talking a lot about diagnostically here, but you don't have to know what the diagnosis is, but you have to have an index of suspicion. And if there's a high enough index of suspicion, we can confirm the diagnosis even after the patient's been criticaled and started on plasma exchange. It's okay for us to stop the treatment once we exclude the diagnosis with the special testing, but we would have a pretty low threshold to transfer the patient if there's a high enough pretest probability. So again, back to the case. I think I made it too easy, but I think most of you were correct. This patient needs plasma exchange.
And we get to the second case, an 85-year-old man feeling generally unwell, quite healthy for his age, only a history of hypertension and diabetes. He now has been having low-grade fevers, a weight loss of about 10 kilograms over the past 3 months, and midnight sweats. You wonder why he didn't go to his general practitioner during these 3 months, but now here they are. The temperature is 37.4, tachycardic to 104, normal blood pressure setting 98 on room air. Again, you run some lab work, and these show low hemoglobin to 95, platelets 64, so thrombocytopenia not as severe as in the previous case, white blood cells 3.8, LDH is 400, creatinine elevated to 120. We might have another chat with Eric, and he might tell us about these von Willebrand macromultimers. But maybe this is more of a straightforward case, and we can go ahead based on the conversation that we already had with him. We check the haptoglobin, which is undetectable. In this case, the INR is slightly elevated, APTT is prolonged, and again, we check the peripheral blood smear, and this shows thrombocytopenia, which is confirmed, and occasional fragments. What is the most likely cause for this patient? Hemolysis and fragmentation. And I'll hand that back to Eric.
Who's seen a case of this before? Or something like this? I think this is a fairly common presentation. The call that I got last night was basically this exact case. An elderly patient who's lost weight, has mild to moderate pancytopenia, more marked by thrombocytopenia. Coags are a bit abnormal. Not really sure what's happening, a bit of acute kidney injury, right? So let's talk about the case. So this is the same slide, different patient. Does the patient have severe thrombocytopenia? No, platelet count was 64. Renal function was relatively preserved. Coags are not normal. There was some fragmentation. There was an undetectable haptoglobin, so there's some element of hemolysis, but the LDH was not 1,300, which would be really high. It was 400, which is like, it's kind of high, right? And then end organ dysfunction, no. The patient didn't present with a stroke syndrome. They're presenting with weight loss, constitutional symptoms. So if we were to break this down, if you were to use this score again, I would agree this would not be screaming TTP to me, and I would not be immediately asking for critical transfer. This patient will need to be admitted likely to internal medicine, but the likelihood of TTP is lower here. So I would be worried, like most of you would be, about cancer in this patient because of the clinical presentation, also the labs. So, and I think here there's likely a component of both cancer and cancer leading to some DIC as well. And the reason is that cancer can increase thrombin generation and then activate the coagulation cascade, and then you might see what we call a bit of low-grade DIC. So you've probably all seen patients who are very septic, very unwell, who are obviously in DIC. This patient is kind of on the borderline, right? So there are some elements of low-grade DIC here, and that's why we're seeing a slight increase in the INR and the APTT. So I would not send off an ADAM TS13 level for this patient. I would not refer this patient for plasma exchange at the outset, given the low pretest probability. And then, like most of you mentioned, I would be looking at cancer as a potential diagnosis. DIC, these are some of the clues that you might look for. So a prolonged INR or APTT. These patients will typically have a low fibrinogen, less than 1.0. Keep in mind, a patient who is unwell, if they're very inflamed, the fibrinogen should typically be high. So even if the fibrinogen is 1, 2, that's not great. So that might be someone who is going to develop more overt DIC, but that's the pattern you would typically see. They will often have thrombocytopenia. Elevated D-dimer concentration could be, in this patient, if they had an elevated D-dimer, it could be from cancer or from some DIC. And you can have fragmentation. You won't have significant fragmentation or schistocytes on your smear, but you might see some fragments as well. So this was a poorly written question, but both of these things could be coexisting, and I think I couldn't fool most of you actually on this one. But again, the key difference is here, we're not worried about TTP. Unfortunately, there's likely something else happening for this patient.
And this brings us to our third case, a 4-year-old male this time, again, previously healthy, which is accompanied to the emergency department for a 4-day history of abdominal pain, diarrhea, nausea, and vomiting. I realize this is not the best case to match a breakfast symposium, but you don't get to choose. And Now the parents are worried because the symptoms are not resolving. The urinary output is probably decreased. There is some blood in the stools, and this alarmed them. And there was also some blood on the toothbrush when he brushed his teeth last night. So they reported also that they've been eating at a street food festival 1 week earlier. What do you think this might be? You start again with lab works. Hemoglobin is 65, platelets down to 45, white blood cells this time increased with a prevalence of neutrophils, creatinine this time up to 280, urea 15.7. We might again choleric, but I feel like I'm not really earning my invitation here, so I will keep going. I ran some more tests. LDH is over 2,000. The normal coagulation times D-dimer and fibrinogen. The peripheral blood smear, now we had a refresh. We are all good at reading it, so maybe we can try to do this on our own. And this is what you see after prepping and coloring your blood smear. Just kidding, this is a hint of what we will see later. This is the blood smear. I don't think I have a pointer here, but you can see some platelets, so there is thrombocytopenia, only a few small purple dots. So it's confirmed that it's not as severe as in the previous case. You might also see some fragments. And again, you confirm the thrombocytopenia and the hemolysis. So which one of the following do you think it's true about this patient? Again, we will give you some time to think of this. 48, we made it to 50 before. So I'm gonna wait for 2 of you, 1 of you. And I think we're happy. Oh. So this patient has a hemolytic uremic syndrome, which is a rare disease, but still the most frequent cause of acute kidney failure in children, typically affecting children below 5 years of age, usually resolving with supportive treatment, but we should know that 3 to 5% of these patients, unfortunately, will die in the acute phase, and that up to 30% will experience long-term renal failure. When to suspect it, obviously with or after a bloody diarrhea. The bad news is that this can happen also with a TTP. In the case of thrombocytopenia, obviously, which is typically less severe than in TTP, when I see schistocytes and hemolytic anemia, so all these features are similar to TTP, the renal failure, it's instead typical of hemolytic uremic syndrome, not so much of TTP, where the renal function is either preserved or only slightly impaired. In this case, the kidney is the main target of the disease, together with the hemolysis and thrombocytopenia. It really involves other organs. Sorry, I skipped the end of the slide, but it really involves other organs. And unlike in the IEC, again, the coagulation times are normal. Fibrinogen is not reduced or consumed. So after confirming the hemolysis, this time the confirmatory diagnosis testing is, of course, the stool culture being positive for Shiga toxin producing E. coli. And it's, as Eric was mentioning earlier, it's exactly the toxin that is mediating this disease with a preference for targeting the kidney. We should, though, know that it's not always the Shiga toxin, the strain, the most famous strain, so the 15787, that is causing hemolytic uremic syndrome. This is the most common strain in North America. However, there are several other strains that can cause this disease producing Shiga toxin. Shigella dysenteria, obviously, as you can tell from the name, is endemic in other countries and can cause hemolytic uremic syndrome, which can also be caused by streptopneumonia and the influenza virus, for example. We should also know that it's not always a burger that causes it. We mentioned street food. That's the presentation that we heard about more typically. And we should know that there are also other causes. Here I just spread some social panic with the splash pads opening this weekend. You might be wondering if you should stop your kids from drinking that water. The answer is there is no way to stop them. And it's not, I would say that it's not that dangerous. But it came to my attention a case of an epidemic in Ontario. Some of you might remember it. It was in the year 2000. The water system in Walkerton was not probably ideally engineered, and there were cattle in the area, farms with cattle, 20% of which were found to produce E. coli, the right strain. And after heavy rains, the water got contaminated. Over 2,000 people got diarrhea, and unfortunately, 22 kids had a hemolytic uremic syndrome. But we should also know that it's not always an outbreak. So outbreaks are the ones that make the news, but it's actually more common to have isolated cases. And this is obviously important to us because it's easy to suspect it when it's an outbreak. It's a bit harder when it's an isolated case. In terms of differential diagnosis, Eric already discussed other forms of TMA. He also touched on complement-mediated HUS, which in this case is something important to bear in mind because, again, it's more common as a first presentation in young patients. Then it can recur later on, but it will be easier when it's a recurrence because hopefully the patient will help us with the diagnosis. This is a disease where the complement is activated, and this outweighs our body's capacity to regulate it. And again, there is a damage in the endothelium that then brings to hemolysis and thrombocytopenia. The other important differential diagnosis is malignant hypertension, which can present, as you know, with obviously kidney failure and a microangiopathic hemolysis, which can come with thrombocytopenia as well. So basically a TMA. In terms of management, most of you were right. IV fluid replacement is important, not necessarily IV, but this was a patient with nausea and vomit. It's important, obviously, also to avoid overload. You might think of dialysis as needed, RBC transfusion. Here I put a threshold of 60, but obviously you will have other things to think about to decide when and if to transfuse these patients. And you can see that we might want to avoid antibiotics. So there was a thought-provoking question, actually one of the answers, and some of you selected it. It's not necessarily wrong, but there are some data hinting that giving antibiotics might make the syndrome worse. And this is basically, we think, because it helps with releasing the toxin. However, these are not definitive evidence, and there's actually a recent meta-analysis that I did report here questioning if this is true. However, in general, we tend to avoid antibiotics in these patients. Platelet transfusions are to be avoided in most cases, antimotility agents, and obviously also NSAIDs, because we don't want to make the platelet function worse. So back to the case, this patient need supportive care. So fluids, maybe dialysis. And I can hand back to Eric for some final remarks before the Q&A.
Okay, hello? Okay, so I always learn to summarize because people forget everything. And it's early in the morning. So take-home points, we talked about describing an approach to TMA. Really, if you come away from this and you know what TMA is, I think that's good. Hemolysis, thrombocytopenia. Remember to order coags and see if we can get a blood film read. Ask a tech, ask internal medicine. It's not difficult actually to look at a smear and identify fragments. And for the consultant, when we hear there are fragments, then we think, oh, okay, maybe there's something happening. Secondly, a differential diagnosis for TMA, it's confusing, but I think it's helpful actually to think about the pathophysiology of it. And really, it's ADAMTS13 is the key driver of TTP. There's complement, Federico just talked about gigatoxin, and then there's the other, which actually is the majority of the cases that you'll see is the other. And it's really differentiating the other from everything else. And then thirdly, we talked about an approach to collaborative care and coordinated care for suspected TMA, depending on where you work. And so a lot of this is asking for help and knowing when to ask for help, and then working with the lab to see if you can get some of these investigations coordinated. Anything to add? Or? Okay, very good. Thank you.
All right, thanks. Great. Hey, thank you to Dr. Gelmini and Tseng for really engaging, really focused, case-based presentations and for giving such clear messaging. So we've had some great questions coming in. The first one, Dr. Tseng, you mentioned the importance of the serum haptoglobin in the workup of these patients. Do you want to just remind us of how that plays in and what that's looking for?
Sure. So haptoglobin is, so if you imagine like when a red cell hemolyzes, free hemoglobin should be inside a red blood cell, but free hemoglobin actually gets released, and that's toxic to the body. And so what haptoglobin does, haptoglobin is another protein that usually circulates. It's made by the liver, and haptoglobin actually quenches that free hemoglobin. It binds to it, and it removes it from the body. And so as a result, the haptoglobin will very quickly be reduced or even undetectable if there's any element of hemolysis. So it's a very sensitive marker for hemolysis, but it's not specific in any way. Haptoglobin can also be reduced if some patients are just born that way and they don't have any detectable haptoglobin when you test them. Liver disease, synthetic dysfunction will often also have a low haptoglobin as well, but it's one of those tests that's it's a first indicator that there could be some element of hemolysis happening.
Excellent. Dr. Gelmini, do you want to add anything or go to the next question?
No.
Okay, so next one is, what's a general rule of thumb on ordering a smear? When do you need to order a smear? Is it for all cases of thrombocytopenia? I don't know who wants to take that one.
So maybe I can tackle this from the emerge perspective, and then you can add what you think. But I would worry more about the hemolytic component, and that's where you want to see the red cells on a smear. In terms of thrombocytopenia, I would say you might want it to confirm it or to see if there are aggregates that might explain a thrombocytopenia. That is actually not true, but this is usually done by the lab technician together with a confirmation in sodium citrate, I would say.
Yeah, I agree.
Great. Next question came in with regards to treatment. So if you're looking at a delay to plasma exchange, is there going to be a role for using blood products to stabilize a patient?
Great question. My internal medicine exam, I had this scenario actually where I was working in a community hospital and the patient clearly had TTP and there was a delay in access. And this could very frequently happen because of delays. So, when we talk about what's the purpose of plasma exchange, remember we said it's twofold. The first is you want to remove that antibody that's affecting ADAMTS13. So that's the removal part. And then, so what plasma? It's kind of like dialysis. You're basically removing the patient's plasma and giving them back normal plasma. So that second part, when you give back normal plasma in the process of exchanging, you're actually giving back ADAMTS13. The reason why you need the exchange is even if you give plasma with ADAMTS13, if the inhibitor is still present, it may not be that effective. Now that being said, if there is a delay to treatment and transfer, then you should start a plasma infusion. So fresh plasma would be the treatment of choice, at least until you can temporize and get the patient over to to a center where they can ultimately receive plasma exchange. The other thing that one could consider doing would be actually insertion of a VAS cath, a dialysis catheter, acknowledging that these patients have quite severe thrombocytopenia, but that's the other thing that can sometimes lead to delays in treatment. But the key would be a plasma infusion. And I would avoid platelet transfusion, actually. So platelet transfusion, theoretically, there may be a concern that it may actually worsen the microthrombotic risk. I kind of use the term as fueling the fire. So I would generally avoid a platelet transfusion unless the patient was bleeding.
Great. And of course, if anyone prefers to use the mics for their questions, please feel free to go ahead. So you mentioned corticosteroids for TMA. What is this going to be high-dose pulse steroids, or would you elaborate on the steroid dosing?
Yes, I think there was a slide with the dosing, but it's a standard high dose that you can start IV. Even the evidence is not very strong, but they're not going to harm the patient likely, and I would start right away if there is a suspect.
Yeah, I agree. So I wouldn't use like the pulse dose. Like, the rheumatology pulse dose is like a gram of Solumedrol. I wouldn't do that, but I would use like a high dose of steroids. So there's no evidence about what the regimen is. You could use 1 milligram per kilogram of prednisone. You could give 125 of Solumedrol. So I would avoid those like mega doses, but you do want to use, as Federico said, like a good dose of prednisone.
Excellent. And there's another question on plasma exchange. Is it going to be doable anywhere that does dialysis, or does it require specialized centers to do plasma exchange?
So I'm not entirely sure about the answer, but this is why we thought that some of these cases would have been interesting from a perspective also of a rural physician, because for sure you won't have capacity to do this in all the centers. In theory, center performing hemodialysis is also equipped to do plasma exchange, but I'm not sure this is the case for every center.
Yeah, it's a really important question, because obviously dialysis is quite widespread, but plasma exchange is not. There's this very specialized expertise, both physician, but more importantly, nursing expertise that goes into the ability to provide a plasma exchange. So most centers that are dialysis centers will not be able to give plasma exchange. So for example, in Hamilton, there are 2 places that do plasma exchange. In Toronto, there are 2 places that do plasma exchange, and every site every city will differ, but it's quite specialized.
And again, from the perspective of a rural emergency department, this brings us back to administering plasma while we wait, right?
Okay, well, we don't have any more questions at the moment that I see, but I don't know if you would want to leave our queued audience here with some final tips before we say goodbye.
I think we can just go over again the fact that thrombocytopenia and hemolytic anemia are not a good thing, especially when they are together. But we stressed many of the concepts already, and maybe we can give you 5 minutes before the start of the other sessions. What do you think?
Yeah, I agree. I think the most important thing is I don't mind hearing about these cases when I'm on call. And I would encourage you to ask for help if you're not sure with these cases, because, as we said, there's a high mortality with these patients. And most of the time it's not TTP, but I would have a low index to ask for help for these patients, because it's a pretty serious condition, TTP.
So you're also willing to wake up at night and put your slippers on?
My daughter wakes me up anyway, so it's all good.
All right. Well, I wanted to provide a big thank you to our great presenters here, Dr. Germini and Dr. Tseng, for a really engaging presentation. Thanks to CAPE and the CAPE Scientific Planning Committee for bringing us all together. Thank you.
Thank you for being here early.